HIS.
HIS? Okay.
So without any further ado, because we have a live case transmission coming behind us, we're going to just touch bases of, like, unfortunately in the first session we haven't touched bases with bicaval approach, but we'll do it now. As we know, the clinical isolated outcome of an isolated TR is worse. The worse the TR, the worse the outcome. And unfortunately, the surgical outcomes of the isolated surgical repair or replacement is still not there, with a ranging 8 to 10% morbidity and mortality in hospitals. And that's because patients are a complex group of patients, and they have multi-organ dysfunction, and they are good until they're not good, and you have to catch them in the sweet spot before they become too late, and you don't get anything to do, even if you went with the treatment. Our guidelines is still behind. It's also like the only guideline that include the first class 1 indication if you're going to go for a left-sided surgery. Other than that, it's all class 2B, C, or 2B. And the European guidelines is the only guidelines at this current stage that involve or included percutaneous approach. So this is a 70-year-old gentleman, hypertensive dyslipidemic, with a previous history of CABG and mitral valve replacement and aortic valve replacement in 2018, and multiple attempts of cardioversion and maintaining the sinus, but unfortunately he's still an AF. There is no much of a coronary to be done, and he presented with shortness of breath, class 2 to 3, with abdominal distension and lower lymphedema. His medication is up, as you can see, they're multiple, and his blood work is doing great, but you can see the creatinine is creeping up, and his pro-BNP almost 3,000. His ECG within right bundle branch block, chest X-ray is unremarkable, and his transthoracic, you can see that we give the patient some time, and in the TEE, or the transthoracic ejection fraction was 35%, TAPSI was 15, PA pressure of 50. The TEE was done to evaluate the patient if he will be suitable for edge-to-edge repair in case of that. So this is the transthoracic, which was done in February, and we have covered this in the morning with the severe TR, and you can see that we were doing, this was mentioned in the morning, some volumetric assessment of the RV function, Bayesian echo, and your TAPSI, and your volumetric. This is a severe TR reaching the IVC, and there's a massive backflow. We talked about this in the morning of surgical assessment of these patients. When you go with a tri-score evaluation, you have a more clinical oriented, and this predict a 14% in hospital mortality. When if you took the Euroscore, which is more technical related, it's just 5.3. So this is like a vast majority between both of them. So I will start encouraging people to consider tri-score in evaluating their patient. Patient was brought to the heart team, and options were delineated. In my case, there was a consideration for edge-to-edge repair, but due to the shadowing from the aortic valve and the mitral, we anticipated that it will be a difficult procedure, and therefore it will not have a optimal result. So we decided to go for a Bicaval device. Our patient had edema, his TAPSI was more than 15, his ejection fraction was more than 30, and his PA pressure less than 65, with a significant wave, so he fulfilled the criteria of having an ideal candidate. We went with the screening, going with a CT scan, and our images considered that the patient is suitable for a 29 in the SVC, and also 35. So here I will go just for the procedure. Usually we did this procedure under conscious sedation, transthoracically guided, because this is not our first radio going with the cases. We had 2 venous access in the left groin and 1 venous access for the valve from the right groin. We did an angio. We introduced safely a wire in the SVC or the jugular. And the reason for that, because as you can see here, you have a very stiff delivery system that you have to confirm is positioning there. The presence of a PA catheter, because you want the belly part in the right side of the picture to be above this PA catheter. So that, because now you're not using TEE, and again, TEE in the SVC will not be as easy to evaluate. So here you can see in the left picture the angiogram showing the conjunction between the suprahepatic vein and the RA, and at the same time you can see the hand of the sonographer picturing exactly where we're going to stand. So we started our deployment. The whole key here, you have to be very slow deployment, controlled deployment, because there is a tendency of the valve, because of its stiffness, to pop up. So you have to control it. So this is an angio to confirm everything before the final deployment, and we have the transthoracic with us, and this is your picture here doing great, everything is fine, there is no backflow going to the liver or the kidney, and this is the whole concept, is because you're using now the RA as a reservoir rather than anything, and now you're eliminating the backflow or the backwash to the liver and the kidney, and therefore protecting them. So this is post-procedure. This is usually doesn't happen acutely, but in our case, you can see there is a substantial decrease in the TR the next day. And almost like you can see from the left picture, there was no more TR, and even the RV started to function better. And even here from the volumetric, it became better. So this was like, for us, like a good, but maybe this was touched in the morning. This patient was caught early in his right-sided failure. We didn't wait for multi-organ dysfunction. We didn't wait for the ascites. We didn't wait for the renal failure to happen. We caught this patient early as possible, and maybe that's why we had good results. And you can see here in the IVC that we have a good positioning, no much introduction in the RA. And you can see also in the Doppler sign, there is no much of a reversal as it was done in the before. So post-procedure, no events. Patient was discharged. Even the TAPSI got better. It was 15, now it's 16. And there was a mild TR. And the PA pressure from 50 dropped to 30. And your RV became much, much better. So we didn't touch this in the morning, but let's go for we have a good result. So is this just a random case, or there's a data supporting the notion or the treatment? So the tric valve has been evaluated in tricus and tricus euro in patient, and it showed a very nice safety profile, and success rate is extremely high with good efficacy, with a very low complication rate. And you can see, if you take it in general, any success procedure, it will lead to better outcome. So as you can see here in this, everything was better after the procedure. You can have 20 points in the Kansas cardiomyopathy scoring system that implemented, they have a very much improved in the quality of life. And that has touched bases in the TriLuminate study in H2H repair. They have also good life quality. So we're also beating in the same bushes at this stage. So when they followed this patient up to 1 year, there was a 91% survival after 1 year. And also their functional outcome became much, much better. And their 6-minute walk became much better despite this trial was ongoing during the COVID lockdown in 2020 and before. So no much of an exercise was implemented at this stage. And that's not only on the patient, even from the echo perspective, there was a better hemodynamic response. And you can see here, as it was delineated in our case, there is a significant drop in the backflow from the RA to the liver. So you can see now you have an improvement in the symptom of the functional outcome of the patient, and also in your hemodynamics from the TAPSI, from the RA. So even from the imaging, it became better, and the ProBNP started to drop, which is a prognostic element on patients with heart failure. So there are some new perspective going on now. Will the presence of a permanent pacemaker in an ICD, because this is the Achilles tendon in H2H repair, image quality when you go for a repair. Well, can you do it? Yes, the answer is yes. This is one of the earliest patients we did. This patient in particular was admitted every 4 to 6 weeks for acetic pack. This happened 4 months ago. Since then, 0 admissions. Since that time, I saw her last Sunday. She's been doing great, and she's becoming more functional, and her weight reduced also. What about having 2 cable implantation? Will the pressure in the RA will increase? Because this is like a concern for many of the operators. Well, there might be an increase in the beginning, but give it some time, and the RA will start to regenerate and adapt and improve. And this is why you have 2 key factors to be considered. You should not have a suprasystemic or very high PA pressure, because your RA is as a reservoir. So the volume has to go somewhere. If your PA pressure and you have very precapillary systolic pulmonary hypertension, that will mess your hemodynamic and your physiology. Second of all, you're going to increase your pulmonary flow circulation. So you have to have a good left ventricular systolic function to some extent, more than 35, to accommodate the upcoming circulation. So this is the post-remodeling that we talk. You can see there was like a big gap in the in the leaflet in of the tricuspid, and this is the valve. After a few months, you can see there the gap started to coapt again and come nearer to each other. What about new indication? What if the patient has a carcinode or epistine anomaly or even a post-heart transplant? Can we consider this therapy? Because we know this, to some extent, is a contraindication in edge-to-edge repair. We're excluding the surgical respective in this treatment methodology, but let's say that, yes, it has been approached in carcinoid patient, in patient with epistine, and even in post-heart transplant patients, it was mentioned and it was treated. What about rheumatic heart valve disease? Well, there is like, I will advise you read this paper on your own with a grain of salt in it, but that is a consideration of it and a new prospect to look into patients with who are contraindicated to do anything, but you might have an option at least to treat them because your goal at the end of the day, prevent hospitalization, improve the quality of the life of the patient as much as possible, and preserve your kidney function and your liver function as much as possible. So is it possible to treat only one cava? There has been attempted to use one cava only because, again, having two valves, it's a bit hefty on the pricing from the perspective. But again, we don't advise that because patient might have develop something like a SVC syndrome on obstruction. And it has been done before, and they ended up with putting the second valve afterward. So what should we do after the patient? Two key factors. Number one, lifelong anticoagulation should be considered either by warfarin or DOAC because this is a low-pressure venous system. So DAPT is not going to make it. So you have to make sure the patient should be on life anticoagulation afterward. And of course, infective endocarditis prophylaxis afterward. The other thing that you have to be careful with it, which was in my first patient, the next day, most of them will start to complaining of shoulder pain. And you have to, now there's like a tendency to take gabapentin prior day or two, and then 7 to 5 days afterward because of the compression on the phrenic nerve. My first patient, he was complaining. The next morning, I saw them consulting orthopedic and doing x-rays to the shoulder. So they weren't aware of the team, but now we should be aware about that. It's happened for the patient. And the final 2 slides, it's easy. It's a fast procedure, and the learning curve is 2 to 5 cases, and usually it takes 40 to 45 minutes skin to skin. And it's already pre-mounted, the system, on the delivery device, which to make much less interaction with the valve and continue the sterility, and it will improve the patients. And 90% you can recapture if you're not happy. It does not disturb the right structure, so you can always go back to the right side or even the pulmonary at any time you want. It does not need general anesthesia once you get the hang of it if you can do transthoracic. It has good visibility markers, as you can see it in the fluoroscopy. And there is no change in the tricuspid annulus size or leaflet or gap limitation. You can do whatever you want, and as we saw, presented it in the whole 2 papers. And finally, 2 premises it has to be taken in consideration.
1 minute, please.
The overall survival of patient with severe TR, we know it. The worse the TR, the worst outcome. So now, if you can improve this TR, we are anticipating some good medical outcome on these patients and even possibility in survival. But maybe we need more data to support that with more patient enrolled. Number 2, once the severe RV dysfunction, dilatation has happened and multi-organ dysfunction has been established, the more operative or interventional procedure mortality will become higher, and maybe you should avoid it. So the TR is not, the tricuspid valve is not forgetting valve anymore, but it's a forgiving valve. So don't take it for granted.